Good morning. My name's Steve Nichols from Melbourne, Australia, and welcome to this World Heart Federation Heart Cafe on optimising proven approaches to improve cholesterol management, which is kindly supported by Merck, and we thank them for that. We have a star-studded group of panellists today from across the globe who all have a major interest in cardiovascular prevention, and in particular how we can more optimally treat dyslipidemia in our communities. It's not just about what we do for our patients. Hopefully by achieving more optimal lipid control, we can prevent many people in the community from becoming a patient in the first place. So the format over the course of the next hour is I have a series of questions for our panelists, and then at the end of that we'll then open it up to the rest of the audience, and then look to wrap this up at 11 o'clock. Just to introduce our panelists from my left and walking across, Dr. Raul Santos, who's Director of the Lipid Clinic at the Heart Institute INCOR and Associate Professor of the University of Sao Paulo in Brazil. Dr. Erin Mikos, cardiologist and Associate Professor of Medicine, Director of Women's Cardiovascular Health at Johns Hopkins. Professor Jose Gonzalez Wanate, who is the head of the Cardiology Service at the University Clinical Hospital and University of Santiago de Compostela in Spain. Dr. Mary McGowan, who is the Chief Medical Officer of Family Heart Foundation in the United States. And last but not least, Dr. Salim Virani, the new Vice Provost for Global Research at the Aga Khan University in Pakistan. Welcome, everybody. So, Erin, welcome. So, first question, what are some promising strategies or initiatives that health systems can implement to improve access to cholesterol screening and optimal care, particularly in underserved communities where cardiovascular disease disparities are more pronounced?
So we definitely need some novel solutions, because what we're currently doing is not working. If you look at data from like the Gould Registry of patients who have ASCVD, 2/3 of those patients, remain with LDL above 70, and over a 2-year period, only 17% had their lipid lowering therapy intensified. So so many high-risk patients are not at goal, and there's a lot of inertia. So what can health systems do? I do think we need to think of novel approaches. I was inspired by the work that was presented by Dr. Alexander Blood that was published in JAMA Cardiology last year from a large health system in Boston, over 10,000 patients with hypertension and elevated cholesterol. And so they used some non-licensed navigators along with pharmacists, nurse practitioners to do a fully sort of remote digital monitoring hypertension and cholesterol management program. Patients would upload their blood pressure medicines and their lipids, and it would be reviewed by this team following protocols, and they would titrate, all sort of remotely. And it was very successful in terms of lipids. The average LDL lowering was about 35 milligrams per deciliter, and more than 94% of patients got to their LDL goal. So that was incredibly successful, all done without physicians. Now, the thing is, it still took personnel. They averaged about 20 phone calls per participant to make the calls and do the titrations. And so when you had 10,000 patients in the study, that's 20,000 calls. So the question is, in terms of that model works, but who pays for the infrastructure of those personnel, the pharmacists to deliver the remote intervention, and can we make this affordable and sustainable outside of research? But they did show that there was similar benefit in both men and women, and across diverse populations there was no difference across subgroups. So everybody seemed to benefit from this remote approach. I definitely think there's a role of telemedicine, especially rural communities. We know that heart disease rates and heart failure is actually higher in rural communities than it is in urban communities, and especially we see these models working for heart failure, where advanced heart failure management things can be delivered by specialists through telemedicine, and I think this works really well for lipids. After initial physical exam to look for stigmata, FFH, a lot of lipid management doesn't necessarily involve an in-person visit, and can be done through approaches like telemedicine to reach communities that may be remote and not have access to coming to these like specialized lipid clinics. So I really think we need a multidisciplinary team, all teams on, all hands on deck, and be thinking about even utilizing maybe non-licensed practitioners, kind of the barbershop model for hypertension. I mean, I think you can train people to follow protocols and utilize multiple personnel to help achieve our goals of lipid control.
So you've kind of probably touched already on the second question in terms of what emerging platforms and initiatives do you see that will then make this better? And I guess we've got to, and we'll ask this question in different ways to other members of the panel, but how can we make sure that what works in urban and rural Maryland can work in less developed parts of the world?
Right. I mean, I think certainly we need to do better for addressing those communities, and I think since it's hard to get clinicians out into those communities, using things like digital approaches, telemedicine will have to help, and leveraging electronic health records. Although maybe Salim, Dr. Varani can comment. They did do a pilot study, giving nudges, electronic messages, nudging when patients weren't at their LDL goal. These electronic messages did help getting more patients on high intensity statins. But surprisingly, a large number of clinicians actually opted out, that they didn't want the digital reminders. So these strategies potentially can work, but there's a lot of fatigue in terms of electronic reminders and nudges when people are not at LDL goal. So I think we still need to figure out strategies that to work to kind of use our electronic health records, our digital technology.
Do you want to talk about the role of health literacy in terms of when we start to try and roll out these initiatives? And as you said, a lot of this can be done remotely, but we also need to be able to do it in ways that patients can kind of understand, and what role that plays in all of this?
Yeah, so I think it's really helpful, especially engaging patient advocates, patient advocacy groups, and maybe Merck can talk about Family Heart. But at least in research, we found it's really helpful to have community members, lay members who are not in medicine, reviewing the study protocols, everything from the consent and everything about the trial, trying to make sure that the language is readable, understandable, accessible to patients. And so I think a lot of our educational material about the importance of LDL, our therapies, how they work, how they benefit, that they need to be reviewed by and input by diverse individuals, making sure that they are culturally sensitive to the population, that the literacy and the readability, and so engaging patient partners to help review these educational materials to make sure that that it is of the right cultural sensitivity and language, improve literacy.
Okay, thank you. Salim, welcome. What strategies or interventions do you believe hold the most promise for improving cholesterol management in low and middle income countries, considering factors such as affordability, accessibility and cultural relevance, and how can those strategies be implemented effectively within existing health infrastructure in those regions to reduce the burden of cardiovascular disease?
Thanks, Stephen. Good morning, everyone. I think I'm not going to say much different than what Aaron just said. I think having spent so much time here in the US and now having moved out to Asia and Africa, I think one thing that I have learned is that the world is actually more similar than different. So the same issues we talked about here, what Aaron was talking about, are similar issues in LMICs as well. I think one of the bigger issues is just the diagnosis part, right? So screening does not happen. I mean, these are countries that are still facing threats from communicable diseases. Now you add all the NCDs, including cholesterol, of course, hypertension and other things are as important, dysglycemia, cardiometabolic risk factors. So I think the first aspect is screening. And even in screening, there are no screening programs per se. So the university I work for has the largest lab network in Pakistan, which is a country of 230 million people. We have about 350 labs all across the country. And we just looked at the last 10 years worth of data. This was 2 years ago. And you would have people with LDL cholesterols of 300, 350. You would have these kids who are coming in and testing, and that must be for a reason, right? But you don't know what happened with those individuals. And this is just the tip of the iceberg. And then when you create these heat maps, you find these pockets where a lot of people have very high cholesterol levels. But there's no screening system per se. So I think, sure, you can have a screening system, but I think till we get there, some opportunistic screening. Kids entering school, I think that might be a good time to get some screening done. Because in rural areas, there are no labs. You're not going to get LDL cholesterol. You're just not going to get it. It's very, very difficult. When women have babies, I mean, at that time, perhaps there's an opportunity to do some screening. That's one aspect in terms of screening. In terms of treatment, I think, task shifting, task sharing are important. There are not enough primary care clinicians in these countries, and I don't believe that the solution lies in specialty care. It does lie in primary care, but as we know, the primary care clinicians have thousands of things they need to take care of. Prevention is one of them in terms of cardiovascular disease. So we'll have to expand that workforce. Now, whether that workforce is your community health workers, lady health workers in some cases, or some community people, lay people who are trained to take care of it in terms of task shifting, that's going to help. The other aspect, I think, and I've seen this model quite a bit in Africa and some parts of Asia, is task sharing. So if somebody is going to these households and talking about, alcohol, or talking about, birth weight of the baby, or taking care of some pregnancy-related stuff, they can do NCDs. The question is that how much can they do before they say, we can't do this. So that's the other aspect where there is a lot that's available. I do believe this patient navigation model, the study that Aaron was mentioning, it's actually a very good model. It worked in COVID in a lot of LMICs where very, very small clinics and hospitals were in touch with these tertiary quaternary medical centers in large cities. So that same model can work when it comes to preventive cardiology, whether that's cholesterol or whether that's hypertension. So that's the other aspect of it that is important. Last but not the least, if you actually look at cell phone penetration, it's more than 90%. Yes, smartphones is 30, 40, 50% depending on where you go, but everybody has a cell phone in these countries. So if you try to do some of these nudges for screening or treatment through text messages, I do believe that it's doable. We actually did a study almost 7 years ago just using plain text messaging. And then it did show that adherence improved a little bit towards screening and towards treatment. So I do believe that there is an opportunity. I do think, though, that at the end of the day, these small interventions or even these large cluster randomized trials only go so far if the system does not take it up. So I think there has to be a lot of this discussion at the level of the policymakers that, look, we do need to shift, we do need to pivot and make sure that NCDs are as important as these communicable diseases, and we need to create a workforce that can sustain NCDs, because task shifting, task sharing is only going to go so far before people tire out that we've just got too much to do. So those are some early thoughts.
And we're talking about a lot of countries where the government is the main payer across the board. So the buck really does stop there. I mean, they're responsible for prevention, and then they're ultimately responsible for off the back end when prevention fails.
Exactly.
So you've already touched on this concept that we shouldn't just assume that we can't roll out technology in low and middle income countries. Are there particular technologies or innovations where you think they might be particularly opportunistic, in those parts of the world?
I mean, some of those I mentioned. So I'm aware of some groups whereby when these community health workers are going to these homes to talk about alcohol, mental health, babies, right? How are they doing in terms of their weight? How's the mom doing after delivery? They have incorporated bits and pieces of this, whereby then they interact with clinicians, right? That model, I think, is a good model. I do believe cell phones are very powerful in these countries. Everybody is doing WhatsApp. I mean, people have data. There is internet connectivity. In some very remote areas, you can have store and forward kind of function that has worked as well. And I do believe that, I think most of us will agree, lipids are very cookie cutter. I mean, cholesterol is not very difficult to manage for most of the basic stuff. So a lot of this is very algorithmic. And with AI now, the way AI works, I do believe that these countries have an opportunity to really leapfrog where you don't need as much human capital in terms of physicians or other healthcare practitioners. And I do believe that we can leverage AI. I don't have an example right now in front of me, but I do believe that a lot can be done because these things are so algorithmic when it comes to hypertension or cholesterol. You only need a very specialized clinician for that top 1-2% of that population that's very, very complex. So I do believe we need to simplify it, not keep it in the hands of a few very specialized individuals, and just let it be, because the model we currently have isn't working. What do we have to lose by making it a little bit more widely available by leveraging technology?
I'm going to ask everybody the literacy question, but in slightly different ways. So, in the end of the day, we need people and communities to engage with whatever it is that we're going to do. They need to own their numbers and do something about it, right? So, and you've already kind of talked about, in a lot of these countries, infectious disease is really what worries people. And I think about, in our own Aboriginal population, which has a terrible cardiovascular profile. What worries, when you go out to those communities, they're far less worried about heart attacks than they are about developing kidney disease, because they all know somebody who's got diabetes, and they all know somebody who's ended up on dialysis, right? And so what about that concept of how do we work with these types of communities to try and make sure that these things are prioritised? They are a leading cause of death in every one of the countries we're talking about. But are there challenges there?
Yes, there are. The first thing is that if you look at a lot of these countries, you don't have national data either. So you don't have very reliable data that you can then communicate with these communities where you're working. So one of the things that I have seen quite often being done, which I think works, is co-creation of intervention. So whenever you're going to go to these communities, you just don't go and say, we're going to do this, we have this health navigator model, we got this model or that model. Actually, the first couple of years you talk to the elders of the community, you get a small group, and the word is co-create. So you get these three big groups. You get the researchers, you get the government people, because somehow you will need some sustainability once you're out of that, once your funding runs out. And then the third is the community. And looking at it from that perspective, holding the community be part of the intervention, but holding them accountable as well. And I think spending a year before you start out with any intervention or any initiative, I think probably pays a lot of dividends in these cases to get their buy-in, and then figuring out how you're going to fund for these initiatives once you're done with the funding that provided the initial push. Those are some things that might work.
Thank you. Rahul, good morning. So it could be simple for us to sit here and connect the dots from, say, well, if we just tested everybody and then we could treat everybody, but there's a pretty important step that kind of underlies all of that, which is around lifestyle. And I wonder if you can give us your thoughts. You've been president of the International Atherosclerosis Society. You've seen cardiovascular prevention across the full range of diversity of economic kind of countries, all of those types of things. So what are your thoughts on the role of lifestyle modifications such as diet and exercise in cholesterol management? how can healthcare providers in different regions of the world effectively support patients in making sustainable lifestyle changes to improve their cardiovascular health?
Wow. Okay, it's great to be here. As been said, most risk factors actually, they really come from genetics and inadequate lifestyles, right? So inadequate diet, no exercise, smoking, etc., and then we get into trouble, right? And for us, it's always a challenge to change that. And one thing that's going on nowadays, because not only the cholesterol, right? We, as Salim said, with this obesogenic environment that we live, the ultra-processed foods, lack of exercise and everything, things really get worse. So we have much more challenges ahead of us than only control cholesterol, right? And definitely for developing regions, I guess it's even worse. So I think the first thing that we need to think about to change this environment is really education, right? It's really literacy. Because we have to empower not only our colleagues, right, healthcare professionals that sometimes they are not aware of the importance of really having a adequate lifestyle. They don't know how to prescribe it. They don't know how to talk with the patients. So we have to have education in different levels. And definitely we have to educate the people, right? Because, and from very early, in my opinion, because they have to be in their minds that to do physical activity, to eat well, not smoke. And this is really a challenge for all of us. This is one thing. The other thing is that, okay, if we find someone who really needs to engage in changing the lifestyle, it's always a challenge. How can we do that? I don't think physicians are able to do that by themselves. We definitely need multi-professional teams to work for that, because physicians don't know first, second, they don't know how to, second, they don't have time. So these are two very important issues that I see, and this is everywhere, just changes the address, right? It's in Brazil, in Pakistan, in US. So this is something really complicated. So definitely we must have multidisciplinary teams. And I keep wondering whether if we don't have, let's say, a prevention clinic, or how can we handle that, right? In Brazil, we have one thing that is called the family health program. And we have visitors that see 60 million people in their homes. Okay, so they visit. And I think initiatives like that, I think could be terrific, to really bring the information and, let's say, try to make patients cope with all the changes that are needed. But unfortunately, even having things like that is not as perfect as it was supposed to be. Even in my country, where we have a program like this, cholesterol is really, really very bad treated in the public system. So definitely, we must improve. You were talking about technology. I think technology can help, and everyone has a phone, right? So maybe finding ways of I don't know, giving hints or nudging people about how to change that. And it's always a challenge, because it's not, in the past we would say, okay, for change cholesterol in the diet, okay, so let's take away saturated fat and trans fat. Nowadays it's much more complicated, because ultra-processed food everywhere is cheaper, especially poorer people that cannot afford to buy more healthy stuff. You don't have time to cook. You work the whole day long. In São Paulo, for instance, you stay for 3 hours in the traffic when you go to your job, to your home, and vice versa. So how can we handle that? This is a really terrible issue. And I think one thing that is important also, because people say, oh, we should exercise, right? Not necessarily exercise. We should have physical activity, right? We can walk. Walk can make a lot of difference. So I think in the end, it really it's I think two-step thing. One thing is really education for everyone, all levels, and even the authorities, right? And the second is really have a team to work together and try to use this newer technology to see whether we can improve for all of us.
So a couple of points of follow-up. So we've already kind of heard the suggestions of, do we try to use schools as an opportunity to go in and screen? if we're going to think about how we target lifestyle of the whole community, I mean, where you start has a really big impact on what your lifestyle is later on. So, are there opportunities to be engaging in education systems around that?
I think so. I think this should be taught even from the basic education level, for the children to know what would be something that is healthy and could make the difference for them in the long term in their lives. So I think we still have a huge road ahead of us regarding education. The big challenge, Steve, I think, is how to really make it work. We've been trying to educate physicians about cholesterol lowering for 30 years, even more, and we still do a lousy job on controlling cholesterol. So what about the rest? What about eating well, doing physical activity, not smoking and everything? So I think it's still a very big challenge for all of us.
So what's the role of co-design and co-create look like from a lifestyle perspective?
I think it's interesting.
Right.
Yeah.
And then the other thing, and you kind of touched on it briefly, is if we're going to think about food supply, for example, and we're going to talk about policy, where does and you talked about educating and improving the literacy of policy makers and governments. What's the role of governments then in seeing how we reduce sugar consumption, saturated fat consumption? A lot of governments are increasingly seeing their role in tobacco. Some better than others, and we've seen some really good examples of that worldwide. But what's the role that governments can be playing from that type of policy perspective?
I think first one would to provide adequate education about this for all of us. I think this because most of our countries, actually, the government is responsible for public education, and that gets most of people, right? This is one. Second one is really to come with, let's say, now we have big let's say things wrote on the packages of the food. Oh, this is high in fat, saturated fat, this is high in sugar, to really scare people a little bit. I think this is important. That's what we did in Brazil, for instance, with cigarettes, right? So you get an ugly photo of somebody with a lung cancer, and people, and fortunately, actually, we have the big reduction in smoking in our country. Also, I think taxes. I think maybe you should make this unhealthy, ultra-processed food costs more, because in some way could, let's say, make they're more or less, let's say, interesting for people to buy. So it's definitely we must have the government with us, and we must talk with the politicians, because otherwise it's not going to change.
Yeah. Now, you said at the start there's obviously more to all of this than just cholesterol. So if we kind of think about these other risk factors, obesity, diabetes, hypertension, and others, does that alter your approach to any of this? Does it complicate it, or is it really one solution should fix everything?
This thing about multimorbidity nowadays is really high, right? It's very important, because okay, we all have inadequate cholesterol. Doesn't mean that we have to take drugs, but we have inadequate cholesterol. And I think half of us, or 60% of us now, are obese. And then we have this, let's say, this addition of different risk factors that are bad for all of us. And one disease can worsen the other one. So we have now, especially with the obesity epidemics, we have lots of people with dysglycemia, diabetes, hypertension, atherogenic dyslipidemia, CKD, sleep apnea, and they all may come together, right? And I think one can make the other worse. So let's think about someone who has a heart attack, who has liver disease, or has CKD, and etc. So first thing, we must increase awareness about these common things that are getting together, because this is the problem nowadays. With we live longer, we have this epidemiological transition, and we have more risk factors. This is one thing. Second thing is to increase awareness about the additive roles of these diseases and the importance of controlling the different risk factors. And coming back a little bit to cholesterol, it has been shown that reducing cholesterol can make a lot of difference for people with diabetes, with people with CKD, with people with liver disease, and it's safe. So definitely you have to work on that. So we have to teach about risk stratification also, and teach about very simple measures to deal with cholesterol that can make a lot of difference for these people.
Great, thank you. I might borrow your microphone for our next panelist, Jose. Good morning, welcome. So we've talked a lot about cholesterol. We've now started to talk about multimorbidity and the other kind of standard risk factors, but we can't come to meetings like this and not hear thousands of presentations about all the new and novel kind of strategies, that approaches that may be driving the disease as well. Whether that's inflammation, novel biomarkers. How do you envision integrating those factors into current risk assessment models and treatment algorithms for cholesterol management?
So good morning, pleased to be here. This is really a very interesting issue, but nowadays all the guidelines and scientific society recommend the risk stratification based on traditional and easy to identify risk factor and lifestyle elements. So when you try to include a new element, a clinical element in the risk stratification, you have to get the information that including this new risk element you can increase the risk stratification of the patient, but it is not the goal. The goal is this new risk stratification with this new clinical element modify your clinical practice, modify your attitude. And nowadays, all the recommendations are based on traditional risk factors for risk stratification. Lifestyle, tobacco, other lifestyles, but hypertension, cholesterol, and all the recommendations are also based on cholesterol and mainly on non-HDL cholesterol or on LDL cholesterol. So we can include inflammation. Yes, we can include inflammation because if you have, for example, high levels of high sensitivity reactive C protein, increases your risk. But what happens? You modify your attitude regarding in this case, the cholesterol control, not at the present time any recommendation about that. You can include, for example, Lp(a). That is really a huge number of papers that if you have a high level of Lp(a), your risk is high. But what happens with Lp(a)? Modify your strategy. Not at the present time. You have to wait to new clinical trials. So, and it's for example the same with remnant cholesterol. If you have an increased remnant cholesterol, your risk could be increased, but also not at the present time information for modify your attitude regarding cholesterol control. So, you have to be a little bit cautious because you need new information. With these new elements, you can refine the risk stratification, but you need a next step. With this new clinical element, you modify your clinical attitude. At the present time, not clear recommendation. The recommendations are based on traditional risk factors, and the recommendations are based on achieving particularly cholesterol levels on LDL. So you have to wait to new clinical trials, to new information. If you include Lp(a), increasing the risk, and you have to treat and you have to target the Lp(a). But you need more information at the present time. And this is very important because the fascination for the new technology is really, but we need more information for including this new clinical element in the risk stratification of the patients. Yeah.
We're working through the brass band in the background, so I thank the panelists and audience for that. I think they're coming along our side. So this concept of these emerging factors both being a risk enhancer
Yeah.
and a pharmacological target,
Yeah.
is a really important point. That and we hear this all the time. Well, why should I measure LP little a? Because I don't have a drug today that lowers that. Or why should I measure HSCRP? Because I don't necessarily have an anti-inflammatory drug, although we could say we do.
Yeah, but I think this is really relevant because many people are using this clinical element for trying to identify a higher risk in the patients. But what about the clinical attitude at the present time? No modify the clinical attitude based on the risk stratification, including the traditional risk factors.
So there is an opportunity here. I mean, we talk about the literacy of the patient, but actually there's the literacy of our clinical community in terms of what do we think the potential of these tests are today. And so, there is an opportunity to be able to do that more. But I guess one of the challenges is, when we're sitting here saying we're simply not measuring LDL cholesterol or glucose enough, how do we expect to get widespread testing of LP little a, HSCRP or whatever?
I think at the present time you have to be a little bit cautious about that, because if you have, for example, a high level of LP little a, or if you have a high level of PCI, high sensitivity PCI, what is your attitude? You modify your attitude, you change your LDL goal, you change your blood pressure goal, you change the drug that you use for achieving this goal. Not evidence at the present time. So you have to be a little bit cautious of including these clinical elements that were associated with an increasing risk, but at the present time, no convincing data that this is a new clinical target. You have to wait for clinical trials current and ongoing.
And in the spirit of talking with our patients and their understandings and their literacy, do we run the risk of just saturating the information we're trying to give to them? If we're struggling to get the message across about cholesterol and blood pressure and sugar and smoking and obesity. So what are the challenges then in trying to then introduce the concept of inflammation or LP little a or other types of factors into those discussions?
Yeah, but you have introduced these elements into the discussion, but for reinforcing the idea that you have to get the goals that was stated in the guideline recommendations, but you have to be a little bit cautious because you can say the patient you have a higher risk, but what to do with this new information? Nothing at the present time. You have to reinforce the idea of treating the traditional risk factors.
We might let the band pass. So maybe we'll move on to the next question. So you're head of a cardiology service. So what are the common challenges or barriers that you see about patients facing in terms of their ability to adhere with cholesterol management strategies, and what strategies have you found effective, both as a clinician but also running a service, in promoting patient engagement and adherence?
Yeah, it depends. It depends, for example, as was mentioned before, education is the main issue, and particularly education in the child, because the child people are the major drivers for modifying the family attitude. So education is one of the key factors, and in many other parts of the world, not in my country, the affordability is also a big challenge, because the affordability, for example, for statins is a big problem in many countries around the globe. But addressing the problem of patient compliance with the medication, including in the Western countries, education is a major issue, because as was repeatedly demonstrated that the educated patients, the compliance is higher than in less educated people. So the compliance with the medication, it depends on the explanation about the disease and the education of the patient. This is an issue. And an important issue you have to use in chronic conditions, that the use of lipid lowering drugs some strategies, for example, the fixed dose combinations of polypills could be useful for increasing the compliance with the medication, and this is a good strategy, using polypills of fixed dose combination, and also with the new strategies, for example, with the new strategies with PCSK9 of inclisiran could be, in some countries, a good opportunity for organizing, for a GP perspective, the patient care pathway, because if you can organize every 6 months a visit to a GP, to a community nurses, not only with focus on cardiovascular, on the risk factor, but also a global health assessment of the patient, could be an opportunity. So education is a major issue in every part of the world. Affordability is an issue in some countries, not in my countries, for example, and also we have to try to use some strategies like this, in this case, polypills or fixed dose combination for improving the compliance, and also the new strategies, for example, PCSK9, and from my perspective, inclisiran is a great opportunity for organize every 6 months a program of follow-up, at least in the very high-risk patients, that every 6 months you can check all the health status of the patient, but based on GPs and community nurses. This is
and there are programs that are trying to develop just traditional vaccine technologies that will target factors such as PCSK9, but potentially Lp(a) and other factors. So it may be that we can develop injectables at relatively low cost. But you do raise an intriguing point that there's the opportunity for us to think about how those injectable biologics, which do come at a cost, might be able to be used in a smart way. If we develop a model of care that may be done in a very cost-effective kind of way in different communities.
Yeah, for sure. But it is, for me, this is to main focus, use of polypills and fixed dose combinations, and use, in this case, in the injectables, that organize the patient care pathway from a GP perspective, a nurse's perspective, using these injectables for organizing the global health care of the patient, not only cardiovascular approach, but also other health problems of the patient. And this is a great opportunity.
Well, thank you, Jose, and thank you for your resilience and patience during the band's march past. Mary, good morning.
Good morning.
Could you share some insights into the unique challenges that families affected by genetic predisposition to dyslipidemia and cardiovascular disease face, and what support and resources does the Foundation provide to address those challenges?
Sure, thanks you, Stephen. Welcome to everybody. I hope you can hear me. There's no brass band. So I'm representing the Family Heart Foundation, where I'm the Chief Medical Officer. And we have families that we serve that have both familial hypercholesterolemia and elevated lipoprotein(a). One of the most significant challenges that young families face when they know, say, a mother or a father has familial hypercholesterolemia is convincing family practitioners, primary care providers, pediatricians to screen the children. And it's a major challenge. One of the challenges that we find with individuals who are adults who know they have familial hypercholesterolemia is convincing primary care providers that their lipid issue is different. An issue where you have been born with markedly elevated LDL cholesterol is very different than gaining weight at 40 and having an elevated LDL. So at the Family Heart Foundation, we really try to provide resources for these families. We provide letters that they can bring to their provider to explain what familial hypercholesterolemia is. And if that doesn't work, we actually have a 600-member specialist map that we can point people to find a specialist in their area. And most importantly, one of the things that Aaron talked about was care navigation. We have one of our care navigators right here, Eric Trico, who, we have a team of care navigators who provide free services to families all over the country and outside the country as well. And we provide them with resources and support that they need to really follow through on what they need to do to get their LDL cholesterol under good control. So we really feel that it's important for people to understand that they spend a vanishingly small amount of time with their primary care provider, with their specialist. We at the Family Heart Foundation can be a resource. We communicate with people via text, via email, via phone call, via Zoom. It's all on the table and it's all free. So I encourage you, familyheart.org, send your patients to us because we can assist you in really giving good care. We don't provide medical care, but we point people in the right direction. Our care navigators are nurse practitioners, public health individuals, as Eric is a trained genetic counselor. So we run the gamut and I oversee that group. And I'm an MD, so we really have everybody covered.
And can you tell us what the role that families and patients have had in co-creation and co-design of what it is that you do?
That is a wonderful question. So the question is, what role do the families have in co-creation? And we totally believe in co-creation. And we have now 280 trained ambassadors, family heart ambassadors, that do peer-to-peer counseling, that help us as we work on federal grants, create the materials that are going to be resonating with people who are just like themselves. So we really do strongly believe in it. It is so crucial to have the patient voice in absolutely everything we do.
Fantastic. So family history. Well, let's move beyond family to family history. Plays a significant role in determining an individual's risk. So how can healthcare providers effectively incorporate family history assessments into routine clinical practice to better identify patients at risk of dyslipidemia and related conditions?
Also a great question. So I'm involved in a number of federal grants through the Family Heart Foundation and also through Dartmouth, where I practice medicine. And one of the things that I'll say is we as healthcare clinicians are really horrible at writing down the family history. Taking a good family history takes minutes, and it's important to document in the EMR. It's also true, however, that families are messy, and sometimes people do not know their family history, whether it's through challenges of your family in particular, or matters of adoption or something like that. And so it's very important to, if you can't get the full family history, to get a lipid profile. And if you get a lipid profile and you find a child with an LDL greater than 160, an adult an LDL greater than 190, you should really be thinking of familial hypercholesterolemia. And then, although children with heterozygous FH don't have physical findings, adults certainly can if they've been untreated. So doing a good physical exam and then acting on the phenotype. If someone looks like they have FH, treat them like they have FH. If somebody, you can also offer genetic testing. And so family history is really, really important. But if somebody doesn't have that information, you just need to continue to act to do the right thing.
And then, we asked Raul about lifestyle. So what are some of the most impactful strategies or interventions from your perspective that families can adopt to promote heart-healthy lifestyles and prevent not only dyslipidemia and other risk factors of cardiovascular disease, and what role does the foundation play in supporting and empowering those activities?
Yeah, that's a great question. So lifestyle is important for everybody. A good diet, an excellent exercise program, important for everybody. We have on our staff a trained, licensed, registered dietitian, and she provides great insight for the patients. But I think when we are talking about when we're talking about families with familial hypercholesterolemia, the diet issue is tricky. FH individuals are just as likely as the rest of the U.S. population to be overweight or obese, like it's close to 70%. So everybody needs good lifestyle, but the conversation in my clinic where somebody may not have a genetic dyslipidemia is a little bit different than the conversation I have with someone with FH. The conversation I have with someone with FH is we need to do really well with lifestyle, but you also need a medication. You're not going to be able to do this alone. And I think if you level set at the beginning, that's really important. But because we have a great resource in our registered dietitian, Mary Card, who I've worked with for almost 30 years. She has great resources. We have webinars, we have information on our website in terms of lifestyle. And when you get down to the nitty gritty in your clinic, the thing to do that takes 2 minutes, and I know nobody has a lot of time, but what do you eat for breakfast, lunch, and supper? How often do you go out for dinner? And those things are really crucial to know. And you can make individual changes. Families can make small changes that can add up. So if somebody gets rid of the cream in their coffee, that's a big step. If somebody cuts back on cheese, ounce for ounce, cheese is worse than red meat. So getting rid of cheese, those little things add up. And having families really enjoy exercise together. Young families can really promote a lifelong love of exercise, hiking, walking, bicycling, all the things that really keeps families together and really gets them engaged in, doing the right thing. And adults can do the same thing. Exercise together is a great thing. Join a group.
Try to convince my kids to come running with me, and that's a little bit more challenging than it should be. But anyway, thank you. As we wrap this up, I'm going to ask each of the panelists just to take 1 minute just to make a kind of final reflection, starting with Rahul. You turn it on.
Well, I think you have discussed different aspects from the same problem, right? And in the end, I think two things are really important. First, awareness, literacy about how these risk factors can really make our lives worse, and how to improve them. I think this is number one. And the second thing is how to implement all the knowledge that we have that can really make the difference for all of us. So definitely we will have to work more and work in different levels. And I like this thing very much of really working with the people who are really the most interested ones on their own health. And we have to find in ways of reaching them and working together with them to really change the scenario. Basically is how I see it.
So, again, we have overwhelming evidence from genetic studies, observational studies, randomized clinical trials that LDL and ApoB are causally related to ASCVD. And we know that's really important to be lower and lower for longer. And I think we wait too long to treat, and we're in a new era. So statins on top of lifestyle are still the first line therapy for both primary and secondary prevention, but we have a lot more options to patients. More oral agents available, injectable medicines, even some like inclisiran, which you can dose every 6 months to help with adherence. And so really coming up with a tailored approach and trying to understand what an individual's barriers are for their control and taking into account patients' preferences, costs, comorbidities. Just like blood pressure, we use combination therapy all the time, and sometimes at the get-go, and be thinking about combination therapy earlier and coming up with an individualized plan, and really listening to the patient and understanding their own personal preferences and concerns, and that takes time. But starting with a patient-centered approach.
So I think that we need to focus on education and avoid the poverty. The poverty is the killer number one around the world. You have to fight against that. Other important issue regarding the cholesterol is that cholesterol is not a risk factor. LDL is not a risk factor. It's an etiological factor. It's etiology of the disease. It's not a risk factor, because sometimes risk factor is not so impressive. It's a risk, increasing risk, but it's an etiological. I think this is important. And at the end, we have to try to optimize the management of the patients, but we need education, we need to avoid poverty, and you need to use, for example, cheap medications that generic statins, use combination therapy, and also try to get more information that if new lipid parameters may be in the future new therapeutic goals, but at the present time, LDL is an etiological factor, and we have to focus on LDL.
I agree with everything that's been said. I think we need to start very young. I think we need, and I know probably most of you are adult physicians, adult healthcare practitioners, but we really need to screen in childhood. We need to follow the American Academy of Pediatrics, the NHLBI, NIH guidelines, which say screen at 2 in a family if there's a family history of cardiovascular disease or FH. Screen universally between 9 and 11. Screen with a lipid panel for children. If we find kids early, particularly with familial hypercholesterolemia, we will find their parents who have not been diagnosed. And we have missed a generation, more than a generation. So we owe it to screen kids, screen their parents. And then remember that you don't have much time. When I see a patient at Dartmouth, I have 20 minutes for a follow-up, I have 40 minutes for a new visit. We at the Family Heart Foundation have more time, and we are willing to give it to your patients. So don't forget about us. We have very well-trained care navigators who will talk to your patients, who will emphasize and reinforce what you have brought to that patient, what you've suggested to the patient for treatment. We also can put those patients in touch with their peers. It's really impressive to see peer pressure at work in a good way through our social media, through our peer support groups. So don't forget about us. We're here to help.
So I think I'll echo all the comments that were made. For this last point, it's interesting that FH is more common than congenital hypothyroidism, but everybody tests for that, but nobody tests for FH. In any case, I think the point I was going to make was that perhaps we've talked about patients, clinicians, healthcare systems. I think even from funders' perspective, I think the model needs to change. I would say that I would urge the funders to perhaps set up a small pie out of the funding panel where you are giving funding for control of risk factors. So you're only going to pay if you show a 5%, 10% improvement in this. So get away from pure science to developmental projects where you are actually showing improvement in terms of control that's outside of your very pure clinical trial setting, and only pay that group if they actually show improvement in control of a risk factor, and open it up outside of healthcare field as well, because a lot of these problems are very complex problems. They cut across various SDGs, they cut across various domains, whether that's social determinants, commercial determinants. Allow the communities to show that we are going to do this over the next 5 years and show you a 10% improvement in our cholesterol levels. We're going to bring our blood pressure levels by 2 or 3 millimeters of mercury. Yes, have some measurement there that's done by independent groups, but open it up beyond just medicine. Let the communities take ownership. Try that model out, because communities will have the design thinking that a lot of us who've been very traditional in terms of how we've been taught to do science probably don't understand as well. So.
On that note, this is a preventable disease, and I think what we've heard over the last hour is it's not just about the clinician and the patient, but it takes a village, and there are lots of solutions that can be part of the village's approach to improving our ability to tackle each of these risk factors and prevent cardiovascular disease. So thank you for joining us. Thank you for your patience during the band. Please join me in thanking our panelists, and enjoy the rest of your meeting.